Thank you very much.
Okay, Gerardo, thank you very much for taking the time. Excellent presentation, great slides. And we'll move along to Alberto Folletti, a neurosurgeon from Italy. Alberto, how are you today? Okay, okay, go ahead, Alberto, go ahead. Yes, I can hear you. Go ahead. It's all yours, Alberto.
Hello.
Introduce yourself and go on to your PowerPoint, please. And welcome.
Sure. So my name is Alberto Folletti. I work in Modena, which is a city in the north part of Italy. I'm not sure you can see.
Okay, hold on. Let me get Geraldo, you need to get off the screen share. Click on the leave screen share at the top of the screen. There's a leave screen share. There you go. Okay, Alberto, it's all yours.
Okay, so as you all know, the European multi-center study on IMPH was designed and initiated to evaluate sensitivity, specificity, and also positive and negative predictive values of CSF TAP test and CSF resistance to outflow in patients with clinical and radiological signs of INPH, and actually the results have been published already.
Excuse me, but did you want to share a PowerPoint? Because we're not seeing in the PowerPoint now.
We're not seeing? Oh,
yeah, well, no, we're not seeing it now.
Okay, wait. Let's see if I can share.
Go on the share and then go to your PowerPoint. There you go.
Okay, can you see it?
Yes, yes. Yes. You want to make it bigger?
Yeah, sure.
Yeah. So it's just a slide on the screen.
It's a bit slow.
It's okay.
Let's see.
That's certainly sufficient if you want to go ahead. That's fine.
Low.
That's fine. That's okay. That'll do.
Maybe I have to restart my
No, that's okay. That's okay. You can continue. We can see the slide. Fine.
Yeah, I know, but I cannot move forward. That's
okay. Okay. I see.
So sorry for this technical problem.
Yeah, Alberto was on a connection's not too good at the hospital.
Yeah.
Probably your Wi-Fi. But let's give it a shot. Let's give it a try.
Yeah. So just a few seconds. Okay.
Yes, we can see it. It's fine. I hope you can move forward.
Still, it doesn't work. Why?
Still, maybe refresh button.
The round colored wheel moving.
Oh, okay. See,
so
what can we do? Can you refresh the screen?
Okay. Maybe it starts now. It starts. Okay.
Okay. Oh, excellent. Okay.
Right. So I was talking about the already published results on the European multi-center study on INPH. But actually, more recently, we noticed that we had such a great amount of data about complications. So we decided to have a look into this problem. 13 centers coming from 9 European countries were included in this European study, and 142 INPH patients were evaluated for a mean time of 40 months. Inclusion criteria were MRI and also symptoms and signs compatible with INPH. And exclusion criteria, of course, if a person refused to participate in the study, but also patients with a short life expectancy or contraindications to surgery, and also an ICP over 18 millimeters of mercury. Prior to surgery and after the inclusion in the study, all patients underwent CSF dynamic test with ICP measuring, resistance to outflow measure, and also a 50 milliliter tap test with walking test, psychometric performance evaluation. And all patients also underwent mini mental state evaluation and were assessed for modified ranking scale and INPH scale. All patients received a Codman Hakim adjustable valve with an opening pressure of 120 millimeters of water. And follow-ups were scheduled at 1, 3, and 12 months. And in each follow-up, of course, all the evaluations, clinical evaluations, were repeated. We had 27 drops out during the study. So the final number of evaluated patients after 12 months was 115 patients. These are the previously published data about resistance to outflow and tap test. And as you can see, there was no correlation with outcome in this study. So only increase in gait task or after CSF tap test correlated with some improvement in INPH score. So the previously published results concluded that R-out and CSF tap test are good for selection of patients for shunt surgery, but they are not indicated for the exclusion of patients from the treatment. And also the published results showed an improvement in both modified ranking scale and INPH scale after VP shunt for INPH patients. But let's go into the topic, the main topic of my talk, so complications. We first have to find a definition of complications for VP shunt. And these are the complications we analyzed: the malposition, infections, subdural hematomas and hygromas, and also the need for further surgeries because of complications, of course. In addition, we also assessed the rate of symptomatic under drainage and over drainage, which are not actually complications, but can make some problems during the assessment of these patients after surgery. As you can see from this graph, we found a symptomatic under drainage in 26% of patients. But as you can see, actually, this amount of patients decreases over time. And actually, after 1 year, there are very, very few patients with this problem. On the contrary, symptomatic over drainage was found in less than 9% of patients, and it's basically solved immediately after 1 to 3 months after surgery. Shunt adjustments were required in about 37% of patients. In 36 patients, this was needed for under or over drainage. So this is something we expect from this kind of surgery. And in 7 patients, shunt adjustment was performed in order to further optimize the treatment. Let's go to real complications. So we found malposition, a complication rate of about 7%, infections less than 1%, subdural hematomas in 6% of cases, and hygromas in 10 patients, so about 8 to 9% of patients. Altogether, these subdural collections required surgical drainage in 2.6% of patients. And shunt surgery was performed in almost 15% of patients. If you have a look into the graph, you can see that basically all these complications are basically solved very rapidly between 1 month and 3 months after surgery. Maybe only hygroma can be found later on in these patients, at least in our study. This shows the most common sites of shunt surgery. The most common sites were the distal and the proximal catheter, followed by valve surgery. And in general, we can say that both symptoms and complications can be reduced very rapidly during the follow-up in the very first months after surgery, as you can see from this graphic. I think this analysis was important to be done because if we have a look into the published literature, we can find some studies which were published, like the one by Heb and Cusimano, which show a very high shunt complication rate, up to 38%, and also very high risk of surgery and mainly permanent neurological deficit, up to 6% of cases in their study. However, we have to notice that in the following published papers about this problem, altogether, this permanent neurological deficit or death risk is reported to be less than 1%. So in conclusion, our study was good not only to assess the rate of complications, but also the trend of complication during the follow-up period. We can conclude that shunt surgery for INPH patients has an acceptably low complication rate, and most complications can be managed non-surgically. This decrease of the rate of complications, as shown also by literature analysis, maybe can be due to technology advances, but also to a careful opening pressure setting and a very good selection of patients. And with the same means, we can, I think, further reduce this complication rate. As I've showed to you, majority of complications and valve adjustments can be solved within 3 to 6 months after surgery. And based on our results, I think a very careful follow-up is needed and required, especially in the first months after surgery. Thank you.